So it should be recording now. And I see a recording button. Okay, I am recording. We're live. If I forget to take a break halfway through or so, please feel free to remind me to take a break. I am going to continue recording through the break because frankly, it's just easier. If I stop the recording, I have no idea what's going to happen afterwards if I'm going to restart it or not. So we have enough committee members attending to take action, do official committee business. For this meeting, we have the option for you guys to call in via the phone or use the audio via Teams. Recommend that you choose one audio option, and also please mute yourself, mute your line when you're not participating so we can avoid any distracting background noises, or so we don't overhear any conversations you may be having on the other hand if someone calls. Also, I am not always good at noticing when folks are raising their hands in Teams. So for those of you who are somewhat new to the committee, just feel free to jump in, interrupt, yell, whatever you do you need to do to get attention. We're a pretty open group. So please just speak up, yell, and interrupt if you're trying to raise your hand and get attention and no one's noticing you. So I've read off the attendees. So that is good. So next we will review the agenda. And I'm going to go off camera and start sharing some documents. Okay. You all should see the agenda, a meeting packet up on your screen. And is it large enough for you guys to see all right? Yay, nay?
I wouldn't mind if it was slightly bigger myself.
Okay. Me too. A little bit more. 100% maybe.
Better?
Yes.
Perfect.
Okay. There we go. Okay, so we have a fairly light agenda with a focus on reviewing the updates to the 3 slide decks that we were able to go over in the previous meeting. And we'll also we'll review and gather your feedback on the 2 other slide decks that we did not get to the last meeting. We're not going to have a Worksite Wellness Council update this month, and I will share a board update, but it will be very, very light. So before we move on to reviewing the minutes, first, are there any questions just about the agenda, about what we're going to be covering today, or does anyone have any suggestions for other items we may want to add and discuss? Okay, so with that, we will spend a few minutes reviewing the minutes. I will pull up the first page of the minutes, but I will let people flip through the minutes on their own computer. Just a note, so there was an action item in here. So if you see there, Rebecca to set up a meeting with the Workday team, just to let you all know, Rebecca did set that meeting up. We had that meeting. Nadine and Angela were able to attend. And so I plan on giving those updates to you all when we actually discuss the challenges to implementation slide deck towards the end of the meeting. And you'll also notice as you review the minutes, in terms of your feedback on the actual slide decks, we'll be coming back around later in the meeting and reviewing those comments as we go over those updated slides. So with that said, I am going to stop talking for a few minutes. I'll give committee members an opportunity to review the minutes. And then I will ask if there's a motion to approve as presented or with modifications. So we will start our 3-minute review now. All right. So do we have any either motions to approve or motions to approve with specific corrections or updates?
This is Steve. I make a motion to approve unless we do have someone who wants to speak up about the corrections or anything.
Okay.
This is Angela. I'll second that.
Okay, so we have a motion and a second motion to approve. I will do a roll call vote, and you can just say yes, no, aye, nay, whatever strikes your fancy. So Cindy,
Yes, sorry.
it's all right. Veronica,
Yes.
Ismailia,
Yes.
Angela,
Yes.
and Steve.
Aye.
All right, he's a pirate today. So the minutes are approved unanimously without corrections. As usual, if you do notice anything you want updated or corrected in the minutes, you can email those corrections to Rebecca and I, and if they're substantial, we'll always let the committee know, perhaps at the next meeting or via email. So moving on to the next agenda item is the board updates. So I'm going to go back down to the agenda. Hope my screen doesn't freeze. There we are. Okay, so fairly light board meeting, and I'm not going to get into the too much of the substance or details. I'll just give a very brief overview. We had our medical carriers come to the board and present updates on COVID-19 vaccines and how their work is coming along. Mercer presented a utilization dashboard, which basically has a snapshot of, the types of claims and where the claims are being approved, where services are being rendered and utilized. We also provided some updates on some of the updates or responses we've made in regards to the Secretary of State audit. The Secretary of State audit had numerous findings. There was a focus, among other things, on how we communicate on communications, as well as on some of our contract monitoring activities. Cindy Bowman gave an update on some of the progress we've made on the communication side. I believe next month I'll be giving an update on the things that we've done in terms of our contract processes and monitoring, which will include some communication work as well. And then the board also heard an IWG or Innovation Work Group update. For those of you who are new on the committee, the Innovation Work Group is a joint committee between PEB and our partner organization, OWEB. OWEB is basically a similar organization to PEB, except it purchases benefits for school district employees rather than state employees. So I'll stop there. Any general questions about those board updates before we move on to our HEM discussions? Okay, not seeing any. We will jump into agenda item number 3. So let me just talk for a couple of minutes about how I plan on attacking this with you guys this afternoon. I think we will start out by looking at the updates to the first 3 slide decks that we reviewed during the last meeting. These slides, again, were updated based on your feedback. There weren't a whole lot of updates. So I think these 3 slides may be kind of fairly close to finalizing. That said, when we get to the slide deck regarding the Health Engagement Model program, the future program, I do have a couple of additional policy type questions that I'll ask you guys to discuss as we're going over the updated slides. Once we go over those first 3 slides that you already provided feedback on, we will then move to the 2 slide decks that we did not have an opportunity to review at the last meeting, and that is the challenges to implementation slides and the next step slides. So again, for folks that are kind of newer to the committee, these are a series of 5 slide decks. It's really part of the same presentation, but we broke it up just to make a better flow and to basically separate out the different topics. So with that said, I think we can now move on to, let's see, starting with the HEM assignment recap slides. So let's go down. These are the recap slides. I'm going to decrease the size of these just a little bit there so we can see the whole slide on there. The first slide you guys had comments on would be slide 7, or on this presentation packet, I believe it's page 11. So let me scroll down. There we go. And if you want to see the full comments you guys made, you can refer back to the minutes. So the comment was to kind of improve or clarify the language around the shorter term stuff we're doing. So I just added a little more language under the updated assignment from board leadership. And if you see the third bullet, are there shorter term interim changes PMAC should pursue, like updated health actions for HEM? So it wasn't a big request or change. Any comments, questions, or feedback on that update? Okay, the next comment was on slide 9 of this slide deck, but again, page 13 of today's meeting packet. And it's this slide, reviewing PEB-specific data. So a couple of comments on these slides, or on this slide. So one, a request to update the worksite wellness language to align with the language in the executive order. And you can see in that second bullet, I actually took those from the executive order, and I referenced the executive order included some exact language just to be clear. The other comment was just to clean up the language a little bit around emotional health. And so I listed it on the first bullet above, and it's the second hash under the first bullet. I use the terminology emotional health and in parentheses, depression and anxiety. So any comments, concerns, questions about those updates to this slide?
Brian, this is Teresa. Just in case someone asks when these are presented, you might want to have in the notes that Executive Order 17.01 or -01 spelled out, just so you have it. It's the Executive Order on State Agency Employee Wellness.
Okay. So yes, one of the things that I will be doing after the content of these slides are finalized by you all is I'll be going back through and adding the actual presentation notes like I would actually be presenting. One of the things that the communications team at Mercer do really well that I don't do well is making the slides very simple, clear. I tend to be really wordy. And so part of their updates were to take away my wordiness and just simplify the messaging in the slides a little bit more. And what I'll do is add my wordiness back in as notes for my own well-being, and also so that you guys have kind of a full abridged version of the presentations to see all the maybe talking points that I may want to either make or have in my back pocket. And that will give you guys an opportunity to make additional comments before we actually go to the board.
I want to add a little bit to this. To adding to Executive Order 1701, the Governor Office just presented to the executive team this the DEI strategic plan for the enterprise, which is going to be very soon presented to the whole enterprise for all staff to see, and is going to have the 10 steps to follow, which is going to be more easier to read what we need to have in there, the language we need to be using, and everything with easy steps. So
And is
that
this
is coming
for-
very soon.
And specifically, Veronica, it's an enterprise solution going through, is it through DAS and the governor's office?
Yes, it's that Sabrina Staromeyer and the governor's office. And I am part of that. We've been working in that strategic plan for the last 2 years.
And does it provide guidance for us on like things to consider regarding health equity, or is it a decision-making type process?
It's process, it's language usage and steps. It's different thing. It can be it's really an equity lens that it can be applied on everything.
Gotcha. So I'm going to recommend, I think Veronica, you and I are going to want to meet then after this meeting, before our next meeting. And I'm going to have you share some more of that information with me, and let's compare it to the health equity screening tool.
Yes.
Because that has gone through kind of the formal channels and already been adopted. So let's do a comparison, and if we need to, we may come back and present some more information to this committee about what that enterprise solution is, and then how we can incorporate it into this work stream, how it fits.
Yeah, because you and in, I can share the document with you. It's not public yet to everybody. It will just share to the enterprise, but I am part of the team. So I can, you can see the document. That's fine. So
Perfect.
yeah, we can meet.
And if you can't share it, you and I can just set up a call. We can.
I've
shared the health equity screening tool, so you and I can always brainstorm and figure out how to bring it back to the committee.
Yeah.
Perfect. All right. Any other comments or feedback on this slide? Okay. On the next slide, the comment was to add a little bit more information about Uplift Oregon and how we're partnering. I'm not sure if I quite captured this, so why don't I give folks a chance to read these bullets and let me know if this is really sufficient or if we need to beef it up a little bit more. And I will just open it up for thoughts or reactions to this language. Any proposed edits on top of this, or does this feel about right to folks?
This is Angela. I think it looks fine to me. I think it covers kind of what we're looking at, making sure that we continue those focuses and partners. So yeah, looks good.
Perfect.
Hey, this is Kelly. I don't know if it would be worth specifying with Uplift Oregon, new employee education, especially. I mean, I think this reads fine. And
well, let me ask you this, Kelly, and maybe the committee is, we've been working and involving Uplift Oregon for a while now, and I'm pretty sure our plans are to continue doing so. Do we need to maybe just briefly talk about who Uplift Oregon is somewhere in this presentation?
Sure.
Okay. Do you feel comfortable maybe emailing Rebecca and I like a 1 or 2 sentence, like what is just a succinct definition for Uplift Oregon?
Okay. Yep, I can do that.
Okay. Yeah, I think that makes sense. Any other thoughts or comments? Okay. So that takes us through the first of the 3 slide decks we reviewed and gathered feedback on. Before we go to the evidence review slide deck, which only had a couple of comments, I do want to ask maybe the committee or propose the committee where I could ask you to approve this this one slide deck that we just went over. However, it feels like as long as we're looking at any of these slide decks and making tweaks, that it's possible that other slides could be impacted. And so it feels to me that rather than asking guys to approve now, that maybe we should wait till we get through all 5 slide decks, and it feels like all of them are somewhat settled, and then we come back with a kind of a larger or an updated just approval for the whole package. What do you guys think about that? Do you think that's kind of a simpler way of doing it?
This is Cindy. I think that would be an easier way to do it.
Okay. Any objections? Okay. So that's what we'll do. I will not ask you for approval yet. We'll get through all the slide decks and then we'll figure out what sort of approval we need based on your feedback. So moving on to the HEM considerations slide deck. Stephen, I know we weren't really planning on having you present anything. I was going to highlight the two comments, specifically if we go to page 29 on this packet. We asked just for a little more clarity, and I'm going to scroll down there so everyone can see it. I think it's the one before, I believe. Okay. So on this slide, we asked just for a little more clarity on what those examples were down below. And I see that you've added some additional language. Do you want to kind of speak to that update on this slide?
Sure. Are you able to hear me?
I can hear you. Yep.
Okay, good. Thanks. This is one, sometimes when I come onto this platform, it defaults to a different microphone. So I want to make sure I have the right one. Thanks. So yes, based upon that request, and as I looked at it again, I said, yeah, I mean, some of this stuff was, if you didn't know the specific names of some of the titles that we had there, it would be hard to understand. So I appreciate that feedback. And what I did to try to address making this more clear is to start with the broad title above the table saying examples of preferred methods of participation by different demographic groups. So this is designed to directly address the question that the board had asked. Does any evidence speak to this or similar programs' relative effectiveness for different types of employees, day versus night shift, office versus field, and so on and so forth? So wanted to then provide some examples that address that specific question. So I changed the titles then for the columns below so that they were not so vendor specific. I had journeys on one of the columns before. That really didn't make much sense to anybody who was not familiar with the industry and how vendors use their terminology. So instead I called that self-service or self-served, self-paced, and then examples of online and learning and coaching. So this doing modules. And then device tracking, steps, electronic scales, electronic blood pressure monitors. So the idea here is then under each of those columns, and starting with the very left column, we've broken down different demographic groups by gender, age, industry, and the neighborhoods they live in, which is some indication of their lifestyle. And you can see then, for example, females over the age of 50 in this slice who worked in manufacturing or service industries and were were generally lower income and in more rural neighborhoods, they preferred telephonic coaching as a preferred modality to interact. And then if you look at younger females in professional services, middle to upper income in suburban neighborhoods, they tended to want to do things at their own pace, self-serve, on demand, when I want to do it, online, and maybe recorded coaching sessions, or even interactive chats with a coach. And then another group still, the under 40 female professional services, upper income, suburban neighborhoods, they were interested in using devices. So Fitbit, Apple Watch, those kinds of things, and these electronic devices that would help monitor their progress toward their goals. So all of this is designed to say, simply, the answer to the board's question is yes. You should take into account the different needs, the different expectations, the different preferences of your whole population, and try to provide as many opportunities as possible.
Thanks, Stephen. And I don't think we had any other requests for substantive changes, Stephen. Did you make any other tweaks that you can recall?
I think it was just more of a reshifting of wording on one, not substantive. So I would say no.
Yeah, I think the other, just the general comment from the committee we received last month was more of a heads up for context that when we're going over some of the evidence or other denser information that a lot of our members won't have the same level of knowledge that this committee does now that the committee's heard all of this stuff multiple times. So just to be mindful that even for the committee members who may not work in healthcare during for your day jobs, I feel like you're probably ahead of the curve in understanding this stuff compared to our members. And so that just highlights the challenges to future communications and how we, could not only communicate about potential program changes, but how we communicate about why those changes are justified. So any other comments from the committee on this specific slide deck? Okay, so next I will flip down or scroll down to the next slide deck, and we did make it through this slide deck, but I will have a couple more questions to ask you guys in addition to going over some additional changes. So this is the slide deck that explains what the kind of future HEM program vision looks like, or what you guys envision the program looking like. It's not intended to include all the details or to say exactly what the program will look like, but rather paint a picture on what the program could look like given the evidence and our membership. The first substantive comment is going to be on page 6 of this slide deck or page 43 of the meeting packet. But first, I'm just going to slowly go through some of these slides just for folks to refamiliarize yourself with the information. So we do a recap of the evidence. Here's the recap of the different employer incentive models that we reviewed. And with the Model 3 highlighted, and if we go down to 43.
I just want to say, slide 42.
Yep.
I just love that picture. Every time I come across it, I don't know.
Just because she looks so over the top happy.
I mean, it's just so cute. Every time I come across it, it just makes me smile. It's just really a sweet picture.
Yeah, I don't think I can recall any pictures I have with my parents like that. My photos are a little more candid in the moment. Okay, future HEM program, slide 43. The comment here was, let's see. That we just wanted to be clear that based on the latest thoughts from the committee, we want members to be able to choose the same theme or path year over year, if that's what they're interested in. Previously, we had talked about requiring the member to select a new theme or path during the initial 3-year measurement period. However, upon further discussion, the committee landed on the fact that we should allow the members to continue picking whatever theme or path they see fit for themselves, and put the onus on PEB to make sure that each theme or path's program options or requirements remain meaningful year to year. And does that make sense to everyone?
Yeah, this is Steve. It does, because I think I was the one that maybe brought up one of those points about that, about whether, at each new year, do they have to start over? Can they continue? And if they continue, do they continue where they left off? Do they restart? Or what the options were if they were actually continuing, right? As you just said, that they keep enough viable choices for someone to continue without just going back and repeating the exact same activity.
Yep. And so I think the third bullet really gets to it, is that members to decide whether to continue on the same theme or path or choose a new one each year.
Brian, this is Teresa. The this may be my not remembering specific conversations we've had, but this whole term of worksite wellness is a little limiting because of the state's approach to buildings reopening, and not everybody will be in the work site as it was known, you know, the office or the field house or whatever department, or, you know, in the car, whatever happened to be your primary workplace. So I'm just wondering about whether we want to say worksite / employee wellness, but then looking at the rest of those bullets and the themes and paths, those really are employee wellness. Those are employees. You go ahead.
What about healthy work environment?
Yeah, because that takes into consideration ergonomics and some of the other things that we want people to be aware of, you know, whether they're working at home or in the office. But yes, I think that's that captures it better.
Okay, and I also just noticed I need to, and I caught this last time and didn't see this before the meeting, but emotional health and behavioral health, I think we want it to be emotional health to be the theme or path. And again, in parentheses, talk about that would include, you know, behavioral health and depression, anxiety. So kind of two things, change worksite wellness to healthy work environment, and try to combine the last two bullets into really something that's driving more towards emotional health at large. Any thoughts, comments, or does anyone disagree with that?
I have something that I would like to be included in there. I would like something about activities for people with disabilities. That is mentioned somewhere in there, because we talk about physical activities, but we're not saying for people with disabilities. And it's always, you know, we talk about activities, but we don't mention by who to who, and we need to add them to that.
That is a good point. We have specifically called out like community and family wellness for some of the like cultural sharing, but in terms of disabilities or is it other abled? I forget the terminology. But folks with disabilities, where do we feel like any of these themes or paths should include those sorts of actions?
I'm wondering if using the word inclusive might encompass that, because to your point, all of the wellness approaches, whether they are things that are happening in the workplace or programs that are offered by PEB and by our carriers, those need to be accessible to all people, no matter what their condition, whether they're, you know, using a wheelchair, whether they are hearing or visually impaired, and so on. But having it be inclusive means no matter what your limitation, the program is accessible. Does
but
that help?
we understand inclusive. They don't. The majority of our staff may not understand what inclusion means. We may have to say activities for able and disabled bodies. We may have to put some type of language there.
So do you think it makes sense to maybe actually just delete physical and just say activity and nutrition, and then parentheses for abled and disabled?
Yes,
Okay.
sometimes, and you know, I am not a specialist in the language you can use, but OHIM or Oregon Health Authority may have somebody that specialize in that language. But you know, my area is for everybody, inclusive for everybody, and I think we need to add it in there, not just saying inclusive. Who are inclusive? And that group is always excluded in everything. Even we say inclusive, they
Well,
always
Veronica, I gotta say, just what you brought up, it supports the fact that even how we laid out these themes or paths are not inclusive to disabled folks. So I think we need to kind of reword that second bullet to make sure that even the name of the theme or path is inclusive in and of itself. And then for the final product, does the committee want me to work with Mercer or others to try to find one or two sample activities for further down in the presentation or elsewhere that we would just have in our back pocket for disabled folks, as an example?
I think it would be helpful to contact someone in the either at the ERG at OHA for differently abled people, first to find out what language we should use, and they may have some suggestions for ways that we can illustrate that.
Yeah, and the specialist there is Bradford Tier.
Well, and you were breaking up, Teresa. Did I hear you volunteer to do that? Is that what you said?
I volunteer to contact ERG and also OIS to see what guidance they have for what language we should use and how we could illustrate the point.
Yeah. Joseph Lowe.
Is that the contact person for the ERG?
Yeah, disability, yes, Joseph.
Would you mind putting that in the chat so I have the name?
Absolutely.
Thank you.
And I say, Ismelia, I think you have your hand up as well.
Oh, yes, this is Ismelia. I was thinking maybe going back to the physical activity and nutrition, being active in nutrition.
So in terms of rewording it, doing
Yes.
it, reframing it in terms of just nutrition and being active.
Yes, being active in nutrition.
Perfect. And then continue just, and do you think it makes sense to have, you know, just in parentheses, something that says for abled and disabled members, or something that's, is there a way to just highlight it as our intent is that this is completely inclusive?
I have no idea about that, because being active, I think, includes everyone, disabled and not disabled people.
We can always make some updates, and then again, we will bring these slides back to the committee before I ask for any formal approval. So we will come up with some language and give you something to react to, and you guys can always kind of tweak that language from there. Does that work? Hello?
Yeah, we hear you. That should work.
Oh, okay. Sorry. I thought I was cut off for a second. So that's what we'll do. We will update that based on your comments. And if we're not sure, we may, you know, we can always provide just a couple options for you guys to react to. Okay, so moving on to, I think the next slide we had a comment on was the next one. So we will just go down. And the comment was to remove some of the date ranges. So what do you guys think about these updates? Do you think it's still too much? Do you think maybe this is the right level of detail? Let's take a minute and review this.
Yeah, this is Angela. The one thing I would suggest, and I think it came up last time as well, is that we remove the actual amount of the incentive and just simply identify at each level, you know, first incentive payment, then level 2 plus level 1 incentive, then level 3 plus level 2 and 1 incentive, so that we have some flexibility in our recommendation about how much that incentive should be.
I love that idea, especially in light of a couple of questions I'll be asking the committee in a little bit. What do other people think about going away from the specific incentive amounts and just framing it as in level 1 incentive plus level 2 incentive, et cetera?
Yeah, I agree with that. It does give us more flexibility and recommendations.
Perfect.
Yeah, I mean, again, just as long as that, as the casual reader, meaning, you know, the worker somewhere, that it's, you know, it's just clear to them. I mean, that's, as long as the language is clear, that they understand when they move from level 1 to level 2, what we're saying in the incentive sentence. So it's not confusing saying So as I was getting $5 on the first level, and I'm getting $7.50 now, or I'm getting I'm getting level 1 and level 2. You know what I mean? So just as long as it's clear, however we get there, it works. If we need to change what's there already, I'm okay with that for sure. Just so, because again, as we know, people will be checking in on with the whole HEM thing on what the incentives are, and they want to make, we want to just make sure with that, whatever the incentives are, that however we express it, that it's easy to understand to the casual reader.
Yep, I agree. And you'll also notice too that there's some language below those bars that just clarifies that everyone starts at level 1 when the year resets. Okay, and then the other comment was on this slide to put something about making sure that during the transition year, we communicate clearly to where we encourage folks to complete activities in levels 2 or 3, even if year 1, we automatically give people all the incentive payments. So you see the parentheses under year 1, under the first bullet, complete level 1 activities, but encourage completing activities in level 2 and 3. However, members automatically receive those incentives. Any comments, suggestions? Okay, if it makes sense, it makes sense. So those were the substantive comments on the HEM recommendation slides. Now I'd like to ask a couple of really policy questions. We just touched on one of them briefly, and that is regarding the incentive structure. We previously talked about just having different varying levels of cash incentives in our paycheck for those 3 levels. So, if once you complete level 1, you may get $5. Once you complete level 2, maybe an additional 10, and so forth. Is the committee open to exploring or having the board explore other incentive structures? So more specifically, what about if level 1 was actually the lower deductible, and then level 2 was an incentive, and level 3 was like an enhanced cash incentive? Is the committee have any strong feelings one way or the other about how the incentives are specifically structured, or is the important thing to make sure the incentives are substantial enough to keep people initially motivated to move through it until they develop that kind of internal motivation?
And this is Stephen, if I may just put in the backdrop here as being the evidence resource here and consultant on the evidence. Some of the things we discussed initially about having something be associated with deductibles or premiums from a behavioral change, behavioral economics perspective is pretty far removed from doing the actual activity and seeing and finding meaning in the incentive. So just to keep that in mind, while it may be appealing to some people, it's not one of those kinds of incentives that necessarily drives engagement and long-term participation. So for whatever it's worth, I just give you that as background.
Yeah, this is Cindy. That was going to be my comment, is in regards to lower deductibles. I don't think that's going to reach as many people as we want to reach, because there are a lot of people that don't even meet their deductible. And I don't know that that would be enough incentive to get them engaged right off the bat.
Okay, so it sounds like so far the committee would prefer to stay within the evidence, which really looks at that more immediate cash incentive. That said, if the board approves this program and we're moving forward and looking at the incentive structure, if based on the incentive budget we would have for cash incentive payments, we're limited, But we would have more room to implement maybe an additional deductible incentive just because of how it'll work actuarially. Is that something the committee would entertain as a fallback? In other words, we follow the evidence, but we know that sometimes given our situation or our members' preferences, we can't always follow it to the T. In this case, if we don't have the budget for the cash incentives we really want to get, would the committee want to explore looking at whether a lower deductible component would kind of move the needle given that budget situation?
This is Angela. I do definitely think it has a potential place in the incentive program because of budget. And also possibly maybe as the step 2 incentive. So you get the initial cash payment for, your initial activities. And with step 2 simply being making your plan, it fits nicely with then giving you a little more flexibility financially when doing the plan if it involves engaging in medical care. And then step 3 being about that next kind of cash incentive tier. But regardless of if it's, includes the deductible changes or is all cash incentive, I think one of my concerns and a concern raised when I shared the potential remodel with some other members is that it's not enough money for them to want to engage in this many activities. It was really clear that the feedback that right now, I get $17.50 a month and I have to sit down one time at the computer and do one thing and say, yes, I did 2 other healthy activities all year. That's it. That's all I have to do. And I get my money each month. And so the difference in the expectations of this program with incentive amount isn't enough to motivate somebody to participate for each of the people I talk to. So I would definitely recommend a higher incentive amount total be a big part of our recommendation. And I do think from Stephen's earlier presentations, looking at the 4 models, both 3 and 4, which were the 2 most evidence-based, totaled around $600 a year in incentive, if I remember correctly. And I think we need to look at trying to reach a target closer to that.
Okay, and I see that Ismelia's hand is up, but I do want to say a quick comment, which is, well, first, let me ask Stephen, in terms of, the evidence and best practices, if our board were to approve a program like this and they were really looking at the incentive structure, if we were to have a limited budget on the cash incentives, do you think it's more supportable by the evidence if we really funnel as much as we can into the cash incentives, and then if we hit that, budget backdrop or limitation, that we look at other stuff like a lower deductible? Is that something that is more supportable than just leading off with implementing a lower deductible into the program?
Excuse me, pardon me, from an evidence-based perspective, the cash incentive, immediate cash or as close to immediate reward is the most motivating and is the most supportable from best practice perspective. Certainly understand and hear the challenges of having a budget. Let me just give you a little more color on that. And I just want to put a qualifier around that dollar amount that you saw in the examples. That just happened to be from an actual client example. If we refer to the HERO Scorecard database, over 2,000 different organizations, the median annual maximum incentive from all models, whether it be premium, differential, deductible reduction, or cash, is around $500. So that's probably more of the break-even point where most organizations go, and above and beyond that is questionable about if you've reached the point of diminishing returns. In other words, for another $100, are you going to get X more % of participation or not? So I just throw that out as a benchmark. 500 to 600 is probably what's out there for most employers.
Okay.
And then I guess, well, I'll just stop there. And if there are any questions, I can go further.
Any questions, Steve?
I mean, I do have a question, I think. it would seem like, so cash incentives that we're talking about seems to be like within our arena here. When we talk about lower deductibles, doesn't that throw that into the provider's arena then? And they would have to be tracking, hey, this person is qualified for a lower deductible than they started out with. I mean, or is that something that the lower deductible is also controlled by this arena? You know what I mean? It's like,
Well,
seems like
that's,
yeah.
we could, yeah, that is something that's within the board's purview, Steve. So that's something we could do. In fact, that's something that, well, right now with him, you qualify for a lower deductible.
But it's by the plan though, right? Not so much.
Well, we require each of our plans to offer a lower deductible based on HEM participation. So our board sets the rules of the game for all of our medical plans. Our boards ultimately are the ones that approve exactly what the covered benefits and the plan designs are, including ultimately approving what the deductible levels are.
Okay.
I'll just throw in, just as a point of consideration, that while that's certainly true, that your board is dictating the plan design, the question is, can the carriers administer it mid-year? Because what I heard the model might be is to initiate that change in deductible somewhere midstream when someone reaches at level 2. That
Absolutely.
could be a challenge.
Yeah, there would be probably a handful or more than a handful of those logistical operational type of issues that we would have to work through. What I envision for the board recommendation is something to the effect of, and Ismail, I see your hand still up, so I apologize. I still see you raising your hand. I could envision us or me adding a slide in the next slide deck we'll go over, the challenges to implementation, where maybe we have a slide dedicated to member motivation versus incentives, where we just raise the issue that, hey, we're not sure whether the current budget for incentives is enough to get our members motivated to do the types of things this new program would ask them or require them to do. So the board, as board members, you're going to have to be kind of ready or willing to provide additional feedback on how this incentive should be structured if you want to move this forward. Also taking into consideration the balancing act that we're trying to make, which is we need to have enough incentives to get people motivated to do this based on everything we're requiring them to do in the program. Are we hitting the mark? Are we scaring people off? And if we're scaring anyone away, is it people that are already self-motivated to be healthy and are already healthy, or are we scaring away folks that could really use the help and support for this program? So I could see adding a slide to the challenges where we just lay it out for the board that, look, this is the issue we're dealing with. Ultimately, if you guys want to move this program forward, you're going to have to give us guidance or otherwise make a decision on what type of incentive, what level you're comfortable with in order to get members to really do this sort of work.
And Brian, I know you want to get to Ismailia, so I apologize for throwing this in there, but just some more context about the cash kind of incentive. With a levels model or quarterly model, one thing that we do know from experience is not everyone will achieve the maximum incentive. So while you may offer $500 a year as a potential maximum incentive, we know from history and we know from human nature that not everyone will do all the required activities to get there. So the actual budget payout will probably be less than what the offer is from a practical standpoint.
Yep.
But that also speaks to the idea of if it's just too easy, like it may currently be, then you're going to have a lot of people doing it and getting maximum incentive. If it requires some meaningful and sustained engagement throughout the year, less people will meet the maximum.
Perfect. So let's get to Ismailia before her arm gets tired, because it's been raised for a long time.
Okay, Ismailia. Okay, so is any way that can both be in the HEM program and let the employee choose between cash incentive or lower deductible? They can choose one or the other.
I think that's a possibility we could look at. I'm just trying to think operationally. We
Because
already provide
there are some
plans.
employees that might decide to say lower my deductible, especially when it's a family. They had to pay $750 before the insurance pay anything.
Yep.
Ryan, I can react to that from what we've seen in the marketplace for the well-being vendors. That would be the platform where this would occur, or would be tracked. There is a very narrow number of vendors that can allow making those choices within the platform. Some can, there are a few that can, but not everyone. So I would say, yes, it's possible. But if that's an absolute requirement for the vendor, the field of likely candidates will be narrow.
Okay. So is it fair to say for the committee, based on what you guys want or what you're seeing, we know the evidence seems to strongly suggest cash incentives are the way to go at a certain level. So is it fair to say that in a perfect world, if we follow the evidence, we would support a cash incentive structure that was significant enough to provide, motivation for a good chunk of our membership to participate? But that if there are any constraints on how much we can spend for cash incentives, that we would want to explore other incentives with the board that could include lower deductibles, or providing the option of lower deductible or cash incentive. Is that a fair statement?
This is Angela. I would say yes, for sure. And I would like to have kind of on our list of other potential incentives be some form of kind of sanctioned workplace wellness time for employees so that they can have the opportunity to have, say, I know this is pushing the limit, but an hour a week of their work time be dedicated to a set of available wellness activities.
Like compensation time they could.
Exactly.
Yep. Okay.
And before we leave this page, could I just ask you, remind me again what OE stands for?
Oh, open enrollment.
Thank you. I just spaced on that one. I couldn't get it. Thank you.
We use a ton of acronyms.
Brian, could I offer another possible idea for an incentive if you have limited budget that some of our clients use?
Please.
Because again, we're trying to, within the context of trying to apply best practice of something that's aligned with relatively close in proximity to when people actually earn the incentive to fulfill on that. And I don't know if this is acceptable within the culture and within the context of the state organization, but some organizations use raffles or sweepstakes. So in other words, if you participate and get to level 1, you might get one chance to put your number in for the quarterly raffle prize or the semi-annual or the every 4-month prize. If you get to level 2, you get 2 chances. And if you get to level 3, you get 3 chances. But the idea is then that you have some relatively substantial prizes. Some do merchandise, some do cash. I even had years ago one, this was before the EEOC guidelines around limits on incentives, gave away a car. But that's no longer allowable to something of that high value. But the idea is that something of meaningful value, could be cash or it could be something other of pretty significant value, that people find meaningful and would be willing to realize that if I participate in these things, I'm going to have a chance to earn something substantial. And your budget would be substantially lower than giving everybody $600 a year, for example.
I love that idea. And Teresa, you have your hands up?
Yes, hello. I'm sorry. The point that was made by, I think it was Angela, right before you and Stephen were talking about time for people to engage in wellness activities. Yeah. Was that you, Angela, who mentioned that?
Yes, it was.
Okay, could you make that point again? I didn't catch all of it. I'm sorry.
No, it's okay. I was just suggesting that a potential incentive as part of participating in the program could be that you could spend some part of your work day participating in wellness activities. So say an hour a week instead of doing your regular day job. You could schedule to participate in a class or go for a walk or whatever it is you want to do for wellness.
Unfortunately, I know that that does conflict with the DHS OHA policy. I don't know about other agency policies. However, as a way kind of sort of around that, I have encouraged wellness committees to communicate and ask their directors and management and leadership to communicate that it's okay for employees to access their PEB benefits during the workday on your computer. If you want to have a video chat with your care provider, if you need to take a class to manage your condition, that be explicitly stated. And so while it might not be a wellness activity per se, like a exercise class, it is benefits that kind of gets around that policy that may say you can't do, your exercise class on work time. Does that make sense?
Yeah, no, I know that that's currently agency policies, and the suggestion would be that perhaps PEB recommend to DAS and to the university system that be a policy that they open up to employees and demonstrate some of the evidence. So I recognize it would take a lot of pushing a mountain, boulder up a mountain, but it's an opportunity for some potential value.
For example, Angela, tell me if I'm wrong here, but for one thing we could do just to illustrate that would be, let's say level 2, requires someone to come up with their own wellness plan. And again, level 3 requires them to actually follow through on the plan. We would work with DAS to see can we get some sort of, so many hours of a specific type of leave for, members who make it through level 2 for them to use completing their level 3 activities. So it may be that we work with DAS and they're like, we can support, 3 hours of a specific type of leave, once those employees, satisfy the first 2 level requirements. And then once you do and you earn those, then essentially you would, I assume, just enter them on your time screens under that specific code, and you would have those 3 hours to use during, whatever that time period is that it would apply to, right? Is that what you're thinking, Angela? Something that? Yep.
Exactly. That's exactly what I was thinking.
Yeah. And honestly, I mean, that would be a huge lift to get through DAS, but honestly, it makes a lot of logical sense with the way that we've envisioned the program so far. It would be great if people could, get so many hours to actually do their wellness activities after they reach a certain level. So I feel comfortable including this as ideas for incentives the board may want to explore if they don't feel they have the cash budget. Again, it feels like based on the evidence, we want to emphasize that the evidence supports those immediate cash payments, primarily, and that in a perfect world, the board would allocate enough funds to cash incentive payments to provide the needed, levels to get people participating. But that if that's a problem, we have other things we would like the board to explore that may not be as supported by evidence, but would be better than the current program. Does that sound about right?
Yeah, this is Steve. I was trying to recall what happens at our place at the OLCC. It seems like they've been very, it's not, I don't think it's in a policy though, but I mean, they've been very allowing of workers to be on their computers, jumping into PEB for whatever they need to do, whether it's their assessments, jumping on for, a quick video about something. We also have it in our contract, and I'm assuming it's in most contracts, but I don't know. For the wellness lunch, so where you can get a 90-minute lunch, but it's on your own time. And so basically, if I was doing an 8 to 5 shift, taking an hour and a half wellness lunch, I would come in at 7:30 to flex my schedule. So I still put in 8 hours. But that was pretty popular. That one was very popular with us. You remember, we also have a garden in our courtyard that was really overseen by our wellness committee. And I'm not clear on, I'd have to find out whether or not they always had to attend to the garden only on their own time, or they were able to carve out some time that was kind of considered the wellness committee work out in the garden. And so therefore they were still on the clock.
Well, I'm guessing the garden looks different nowadays that OLCC is doing cannabis too.
Yeah, yeah,
It's
I've tried.
changed.
It's been there for a while. Yeah,
Yeah.
yeah. Can we get a whole new? Yeah, I don't think we've gone that far quite yet, but this is an enclosed area, so it would be protected.
No, that's a good point. So, how does the committee feel just about this conversation? Kind of about some of the statements I've made about the preferences for cash incentives, but having other options, knowing that we may not have the budget. You guys comfortable with that approach and trying to add slides to either the HEM slide deck or maybe the next slide deck will go over the challenges to implementation slide deck that really hits this home, or what do you think?
I guess one question I have is for, say, for example, just the basic, I've been with the Kaiser plan where you basically pay $5 when you need to on a visit. So, I mean, as long as I've been with the state, I still have to admit I'm a little, I don't have a sense of deductible in that world. I just feel like it's, I use them 5 or 7 times a year and I pay $5 and then I go on my way. So in that scenario, I'm not sure what the lower deductible would really mean.
Yeah, I honestly, for me, I'm a single person who doesn't have a lot of medical expenses. So for me, that deductible incentive isn't immediate compared to a cash incentive. That said, I have some colleagues, who, may have some dependents, a spouse, domestic partner who has very consistent medical cost every year, and always, has to hit the deductible. And so for those members, having some sort of deductible waiver will be meaningful to them. But again, I think that's probably why the evidence kind of points to the cash incentives, because that's more of an immediate reward. It's kind of closer, it's tied closer to the action you're actually taking. So other thoughts? Are you all supportive of that approach on the incentives? I saw Angela gave a thumbs up. But are other folks comfortable with that?
So it would include both, either or? You mean like either the cash or the lower deductible?
Yeah, well, I think what, again, the board asked us to really follow the evidence. So I think the way we want to frame it is the evidence clearly says that the immediate cash incentives are the most effective. So in a perfect world, the recommendation would be for the board to fund the incentive at a high enough level to provide the level of incentives we think would be adequate to motivate members. And that if they didn't feel they had the budget to basically implement that level of cash incentive, that the committee would be open to hearing other incentive options, such as lower deductibles. I think the work time could be a different deal that we call out separately, because that's not so much cost. That's really about collective bargaining and DAS. But it's really, if we follow the evidence, it's asking the board to fund the cash incentive. That's the first priority. If they can fund it at a level that's high enough, that kind of makes us all feel better about that being the only incentives. And if they don't, the fallback we would look to is whether there are other incentives like lower deductibles that the board could explore as a fallback. But again, the preference would be higher level cash incentives based on the evidence.
So if we do the higher level cash incentives, then would we be reworking that earlier slide about that showed the incentive amounts? Then we'd be messing with that amount?
No, it's up to the committee. I don't feel like we need to include any of those specific amounts. I think we could include examples for kind of to paint a picture, but I think it could be simple. I think the recommendation could be as simple as we really think these levels should be based on cash incentives, because that's where the evidence says. We don't think the current program's incentive levels are sufficient enough to move behavior. So we think that even the cash incentives among these three levels would need to have a discussion, and we would need to get them at a level enough to where we felt pretty good that it would incentivize that initial member behavior. I don't feel like we need to put specific dollar amounts, because evidence may change over the next couple of years about what that dollar target is. I think the message I want to give to the board is, look, if this is evidence-based, you are going to need to be prepared to fund the cash incentives if we're strictly going over the evidence. And looking at the board and saying, if you don't feel comfortable budgeting based on that level of cash incentive, there are some other options we'll look at. They're just not as supported by the evidence. And really, I think for an advisory committee, it's fair for you to tell the board that that's your decision to make. Here's some options that we're painting, but ultimately you set the budget, you set the priorities. So we need direction on what you want us to do to either come up with some more specific options, or we just want some guidance on what you prefer, board. Does that make sense? I felt like I did a lot of talking.
This is Angela. I think that's exactly the message that I think is important to convey to the board. So I think you had it spot on.
Yeah, I agree also.
I have a question. This is Ismelia. Brian, when you say about lower deductible, how much it will be the lower deductible?
So again, that would depend on the board and the budget. I don't think there is necessarily a predefined limit on what we could come up with or recommend, but it does cost money. You know, the lower deductible, the higher the cost to us, the plan sponsor and premiums, because those are costs that are still being incurred by the medical system, and someone has to pay for them. It's just not the member. So I know that's a non-answer, but we would work with the board and with Mercer and the actuaries to figure out what level of deductible changes would have a specific dollar impact and what we could afford taking on from a budget perspective.
And Ryan, this may not be the right forum for this discussion, but I think this committee knows it, and it's public knowledge. I think it's in the governor's mandate. It's public that the trend for the health plan needs to be below 3.4% annually. So adding any additional cost to the plan, it's real dollars, as you said, and
Yep. I'm
sure the board will consider that.
Yep. So does that make sense, Ismelia? It's I know it's kind of a non-answer, but
yes,
there's not a specific limit. We would just have to budget it, and we'd have to talk to people at Mercer that are definitely much smarter than I am.
Yes, it does, because it will be great to know what will be a lower deductible for the employees or employees and families or employees and children.
Correct. Yep.
Yeah.
Okay, so we actually made it through that third slide deck. We have two more slide decks to go over that we have not reviewed yet, but they're a little simpler than what we've gone over so far. I will say there was another policy question I'm going to ask you really quick, and that's after we do and update all these slides, would it be helpful with the final recommendation to maybe have a couple separate slides that actually could walk or use kind of fictitious members as an example of what the program would actually look like for them, where we would actually walk through, as an example, you know, what a future HEM program could look like through these all three levels for Teresa or for Brian, or you know, something that's more real world and illustrates the program.
I think something that would be like a real life example would probably be a great thing to include if we could do that. That would really help people, I think, understand what they're looking at here as they go through these little year 1, year 2 adjustment things, or whatever that might be.
Perfect.
I might suggest that we take a quick break, maybe.
Yep, I was getting this last policy question out of the way before we go to the slide deck 4. I was going to say we should take do we usually do 5 or 10? We do a 5-minute.
Yeah, 5's good. Oh, 10. I see a 10.
Teresa's saying 10. Okay, so we will reconvene at 1:30. I am going to go on mute, but I'm going to continue recording, and I will try to facilitate our last 30 minutes fairly speedily. I'll try to keep us on point. I think it'll be fine. So With that said, we will break and recommence in 10 minutes. All right, we'll have another minute or so, and then we will get going again. And I pulled up the presentation we'll be going over next, so we'll be ready to hit the ground running. Veronica, did you just say I'm making you dizzy? Am I speaking too fast or mumbling?
I was looking at another screen here and suddenly I saw the screen scrolling fast. I was like, what's going on? It was you.
I was actually worried. I was using this opportunity to do some stretches, stretch my back and legs. So I was actually worried that my camera was on while I was stretching and you were seeing me and you're like, you're making me dizzy, Brian.
Yeah.
Okay. So we will pick up with the challenges to implementation slide deck. And I have it pulled up on the shared screen. So I'm just going to start going through it. So one thing I wanted to just mention that, these slides, the intent is, since we're not presenting or recommending a specific program with all these detailed components, but rather we're painting a picture, it's important to also paint a picture of what sort of challenges we're going to have to operationalize and implement this type of programs. So the intent of these slides here is just to give the board a heads up that if the board likes this idea of a new HEM program, that there is still much work left for both the board to do, staff, and probably PMAC as well. So that's kind of how I would frame the challenges to implementation slides. So starting off with the overview, this is just what I'm capturing in these slides. So we'll talk about the challenges, including that this will include a large or require a large RFP. There's a lot of different systems and infrastructure that we need to accommodate. There's a lot of regulatory issues we need to work through. And then there's always the cost and budget parameters that we briefly touched on in our earlier discussion. So starting with the challenges associated with a large procurement, I don't know how many people have been through the whole procurement and contracting work or through a project dealing with procurements, but it's a lot of work. And an RFP to do what we want to do for this program, an RFP that would result in having a wellness vendor provide this sort of platform and all the infrastructure we would need to make this happen would be a very large and complicated RFP. The board, our board is slowly moving towards some sort of future medical RFP. So one of the decisions the board would have to make about this project is whether we would do a standalone wellness vendor and platform RFP, or whether this would be just a component within a larger comprehensive medical and pharmacy RFP. And the other challenge would be, because an RFP is just a big project, we'd have to prioritize it with all of our other work and business. Any questions or comments? Okay, in terms of the systems and infrastructures, we've talked in previous meetings about the fact that some of our ideas for moving forward different trainings or courses would impact Workday, or that we should at least try to take advantage of existing infrastructure such as Workday. And that also HEM, the incentive payments, currently run through payroll, so we are going to have to work with payroll to make sure they can accommodate different levels of incentives at different times of the year. We do have updates here. So I mentioned earlier that Rebecca set up a meeting with Workday. Angela, Nadine, and I met with members of the Workday team. Long story short, from a payroll perspective, it seems like the OSPS, the payroll system at the state, can handle varying levels of incentive payments that could change month to month, and that they envision something similar to what I envision, which is that ultimately the wellness vendor, whoever we would have under contract, would probably interface with payroll directly and send them the files and information they would need to do the incentive payments through payroll. We also got generally good news about, I'd say generally good news about the training and Workday. Workday, they have an ability to add external users and track their training courses. So for example, for folks, at the universities, Workday could be an option. One drawback with Workday, and it could be really significant for this program, is currently supervisors can see all of the completed trainings of their employees. So if we wanted to have Workday house some of these HEM program requirements, I'm just not so sure that would be a good fit given that functionality currently. If we have stuff about how to access different benefits or types of benefits, I'm just not so sure that's the type of thing that we want supervisors knowing about, nor do they need to know about that sort of thing. So that is one challenge that we would have to work through if we want to use Workday, is finding a way for any of these program requirements that we don't feel are appropriate for anyone to know about, that they would need to be screened from supervisors and from other people from viewing them. So let me stop there. Any questions, any concerns? Angela, did you have anything else you would want to add from those discussions?
No, nothing else to add. I think you recapped it just right.
Perfect.
Quick question.
Yeah.
So when you speak in terms of whether Workday could handle it or they couldn't handle it, are there other options other than Workday? I thought everything was moving to Workday.
Yeah, probably the actual vendor. If we go through an RFP and get in contract with a wellness platform vendor, this is something that we could explore having them track and administer. Stephen, off the top of your head, I don't know if this is something that's typically within their wheelhouse. It feels like it's not an overly complicated functionality to track certain trainings like this in a system.
Right. It is a common feature for the sophisticated well-being platforms to have content, educational programs, and the other interactive kinds of activities, coaching and training seminars and webinars and videos and audios. All those kinds of things can be contained on the more sophisticated well-being vendor platforms. And the advantage to doing it there, as opposed to through a Workday would then have to interface with your incentive
Correct.
tracking on the well-being platform anyway. So it would simplify it, I think, and should be I would think, a core capability for a vendor that you would select.
Yeah. Now that said, I think if the board wants to move this program forward, we would still, as part of implementation and planning, work with Workday to see if we can make it work. Because again, I'll channel Nadine here. The state pays a lot of money for this solution for Workday, not the whole state, but portions of the state. And so if the state's already made investments and there's a possibility that the infrastructure could meet our needs, then we at least have to explore to see if it'll work. At the very least, we have a kind of owe a due diligence to see what existing infrastructure could work for this program before we spend money elsewhere.
And also, isn't there, what's the current payroll system is whatever OSSPP or whatever it's called. And now I know, DAS has certainly let the unions know that there's a new payroll system that they want to get installed under Workday come next July 2022. So payroll and all our timesheets, everything would be everything would be in Workday at that point. So it seems like Workday is going to, if that's the direction they're going in, there is going to have to be some interface of some sort. So again, it goes back to your original concern, Brian, which is about management having access to not really medical issues, but certainly our health, what we're doing with our own health. And that does seem a little intrusive.
Yep. And with payroll, I think it's a different situation in that for the state payroll system, it seemed like there were really no concerns on their end. But what we have to remember is OSPS is only one payroll system among the PEP group. We have lottery, the universities. I think there are some other, public corporations that do their own payroll. So the state's fragmented. Even at our level as a plan sponsor, it's really fragmented. And so part of our homework will be seeing what enterprise solutions are out there that could work. But then also for the ones that can work, we still have the conversation about, well, does that even make sense for the university folks? Does that make sense for lottery? So a lot of stuff to go through for implementation, certainly. Any other comments, thoughts?
Brian, given the previous discussion about the potential for changing deductibles as a potential incentive model, do you want to add a bullet here for medical carriers accommodating changes in deductibles?
Yeah, I think we should. Definitely add a bullet about, depending on the program incentives or design, there could be some carrier systems that we need to interface with or otherwise work with. Good catch. Yeah, other thoughts? Okay, so we also have a slide on regulatory compliance. Not a whole lot to add here, just that this is kind of part of all the policy type stuff we do. And with a wellness program like this, there will be a whole regulatory analysis about, kind of what laws we need to follow, what sort of, appeals or alternatives do we have to offer, et cetera. So I listed just a few of the big buckets: ADA, IRS tax regs. We have ACA and wellness program regulations. These are all typical things that staff and the consultant and DOJ would work through as we're implementing. Any questions or concerns about that slide? Okay, here's a slide on the cost and budget. So there's going to be both startup and ongoing cost and budget challenges. Startup costs can include just the building and customizing of the wellness platform. Building the interfaces to allow the different systems to speak to each other. So the wellness platform interfacing with the carrier systems, wellness platform interfacing with payroll systems, et cetera. And then do we need to update our current systems to accommodate HEM requirements? And that should read, does PEB need to update its current eligibility and enrollment system to accommodate HEM requirements as well? So any questions?
This is Angela. I do recommend on this slide and the next one we add the cost of staff engagement and communication, because one of the things that will be needed is, at least at the beginning with the model, will be that engagement out to staff to say, hey, here's this new model, here's how you participate in it, here's what you do. Either as a built-in cost for the vendor to help provide that, or somebody within, within PEB or within one of the agencies to help provide that.
Yep, that's a good catch. Other thoughts? Okay, and then here is a slide with the ongoing costs and maintenance. So vendor admin fees. A wellness vendor isn't going to do this for free. They'll have some sort of costs associated with the work. The actual program incentives will need to be funded. And then if we want to offer any new programs as part of HEM or as a portion of HEM, ultimately we need to pay for those new offerings. So let me stop there. Any final thoughts or questions about the challenges slide deck? As we noted in the last discussion before the break, I think I'd like to add, again, a slide or two on the challenge about appropriate level of incentive and cash incentive to move the needle, and what the other options are if there's not the budget for a cash incentive. Are you guys still comfortable with me working with folks to try to take a stab at adding a slide as that being one of the challenges we'll face? Is that a yes? You're good with me developing something for you to react to?
Yes.
Perfect. Okay. So this is the last slide deck we're gonna cover today. Again, fairly straightforward, because really what we're asking the committee to do is, if they like this idea, we need the board to tell us what's next for us. So we initially started recapping kind of what the recent work is. So as the work continues to develop this new vision for HAM, we've also been developing and adopting an infrastructure to support health equity, and we've been partnering with various stakeholders. The next steps we've identified for health equity is to reinforce the importance of recruiting members who have worked professionally in health equity, who have diverse backgrounds, personal experiences, recruiting members with desired characteristics. I'll just say we're going to reword that, because again, that makes us who participate on the committee, we're not checkboxes, we're people. So I think we want to say recruit committee members, again, who either have professional experience in health equity or just bring a diverse background to the table. We've reviewed and adopted a health equity screening tool, and that will continue to be updated based on how we see fit, how it's used. We will be getting our health equity work group up off the ground the beginning of August, so I expect we will be looking at the health equity screening tool a little bit more in the fall as that work group's work gets off the table. And then just the question is, how else can PMAC and the council support health equity? And again, we're going to be asking the board for direction on what we should be doing next. In terms of partnering with stakeholders, we continue to partner with the council, and I think we should probably spell that out a little more. The Worksite Wellness Coordinating Council, Uplift Oregon, and the questions: what other stakeholders should we partner with to move the work forward? How does the board envision PMAC and the council coordinating or aligning going forward? To that end, I will say Teresa and I and Mercer are going to do a little more work and some ideas on kind of the role the council can play versus PMAC, and so we may have some more information in the next month or two to add. But for now, I think the point is really asking the board for direction. It's been a while since they've assigned or at least updated this assignment for us, and now that we're bringing it back to them, we need the board to tell us what does the board want PMAC to prioritize going forward. Is there anything that maybe PMAC's not aware of that the board wants it to jump on? And then again, next steps for the HEM program specifically. So in the short term, is the board interested in you guys modifying any of the any of the HEM program in the short term? So like, do they want us to recommend new types of health actions that better align with recent priorities like health equity, or what does the board want PMAC to do while this long-term vision is being either mulled over or rolled out over a few years? Long-term, we need to ask the board what it wants PMAC or the council to review in terms of the future HEM program vision before we design the RFP. So if the board wants us to move forward with this project, how much is it going to want the council and PMAC to drive some of the details, or is it just going to say Mercer and staff have at it? And then how much does it want PMAC to be involved in assisting developing the proposal requirements, like those involved around health equity? So any other thoughts or comments about some of these questions that we'll be asking the board? And that is the end of that slide deck, where again, we just asked the board, is there any other ideas or guidance for our work going forward? And I am going to stop sharing at this point. Gracie. All righty. So, any thoughts? just on the next steps, are there any different sorts of questions that you guys may want to ask the board, or just any other thoughts?
I have this is Ismelia, Brian. I just have a question. When these changes are going to be happening? Next year or?
Oh, no, not next year. So I laugh because we've had this conversation a few times with PMAC. If the board approves of this recommendation, or if they're interested in moving this sort of program forward, it is a huge lift for the organization and for staff. So realistically, if they approve it, I see it as a 3 to 5 year implementation period. Typically, for RFPs for procurements, when we're doing a benefit procurement or a consulting procurement or anything that's just kind of complicated, we usually like to give ourselves a full, 36 months, 18 months to figure out how to design it, develop it, and then 18 months to actually administer the RFP, negotiate a contract, and get through the initial transition and implementation. So it is not something that will happen next year nor the year after. It's literally a 3 to 5 year deal if the board likes this and wants to prioritize it accordingly.
Okay, thank you.
Yeah, and I will say, it's frustrating as someone who works on something like this to have something be that far off. On the other hand, one of the reasons why PMAC was created was years ago, PEB implemented a whole bunch of changes overnight, seemingly. We introduced HEM, we introduced deductibles for the first time, and some different cost share and benefit changes all in one shot. It didn't go well. So I actually think having a 3 to 5 year rollout for a program like this, while it's frustrating for those of us who just want to see action and move stuff forward, it's probably good for our membership as a whole, because we're going to need time, again, as I think it was Angela mentioned, communicating. We're going to have a very robust communication plan. We're going to have to justify the program requirements. I don't think it's enough for our population just to say this is what the evidence says. We're going to have to justify, why we're asking members who want to participate to take more program requirements on. Regardless of having more of an incentive, we still have to explain to them why this is not only in PEB's best interest, but all of our best interests. Does that make sense?
Yeah. And I'm also struck by what you had said earlier about, some sort of, I think it was coming out of Angela, but you also said it, Brian, that, using, take a typical person and have them be the example of, starting out with open enrollment, going through level 1, level 2, maybe, and then maybe have another one that shows going from the first year to the second year. If I was at level 3 in my particular path, as I go into this new one, show that, if I stay on the same path, what those activities might look like, or if I change paths, just so people can see how it, what the process actually looks like that we're presenting in just 3 little blocks, you know what I mean? So I think those 3 blocks won't be, a lot of people will go, okay, yeah, but how does this work? And I think something that would be instructional to show that would be very helpful.
Yeah, I could envision something like we go over the slide deck for the HEM program. We're like, okay, this is what we envision, but this is a lot of dense stuff if you really try to mentally compare it to what we currently have in real time. So we're going to go over all these characteristics, but let's take a step back after we do that. And then we'll just follow, John and Rebecca through this process. And, after we do the nuts and bolts, we're just going to, follow John and Rebecca for through the first 2 years of the program, just to illustrate what the member experience will look like. And I think that would be, personally, I'm really thinking that's going to be critical when we go to the board, because this is a lot of stuff and we still have to rehash stuff every once in a while. And we've gone over this a few times. So I think painting a picture, a real world picture, is going to be critical for the board to get it.
Yeah, and it's going to be critical for the members too, because they'll be going, what? Yeah, so anything that will show them how the process goes would be very helpful too.
Yep. So any other thoughts, questions, concerns? Okay, so what do I envision for next steps? I think we will do the same thing that we did for this month is I will go back and work with Mercer and our communications team to update the slide decks again based on all your feedback. If we have enough bandwidth, we may also create that other slide deck just to show, a couple examples of what the program would look like in the real world for members. And then I think what we'll want to do is we'll come back in August. I think we want to keep the agenda dedicated to just getting this stuff finalized. We are having a combined meeting with the council August 4th. And there's nothing that you all need to prepare for. That's more of a put your feet up, listen to the presentations, get to know about PEB's data. And it's basically intended to get everyone up to speed and on the same page in terms of PEB's business. So we will have the Worksite Wellness Coordinating Council there. We will have you guys there, and we've invited all PEB OEB staff, as well as I think we'll have a few members from our newly seated Health Equity Work Group there. I'm not sure. Let me look at the calendar. I can't recall if we still have a normal August meeting on the books. And we do, August 19th. So my gut tells me we'll probably have the combined meeting August 4th, and we probably should still have the regularly scheduled August meeting, but limit it to just the updated HEM slides and getting final approval from you guys. What do you think? That sound like a plan? Sound okay? Steve's giving a thumbs up. Yay, nay? Committee members, you good with that?
Sounds
We're up
good
to
to me.
5 thumbs.
Sorry to harp. It's just I'm not a decision maker. I just support you guys. I just want to make sure I'm doing things you're comfortable with and it aligns with your vision. So you're good with it? Good with this approach coming back? Again, if you can make it to the August 4th meeting, so Veronica, Ismailia, it may be really helpful for you guys and even Kelly because it's going to be broad-based presentations about PEB, utilization, enrollment information about the Health Equity Work Group. You won't have to prepare. You can just sit back and listen. And then we'll come back during the regularly scheduled meeting in August and we'll have updated slides and see if we can get your approval to move forward. And if so, we're probably looking at a September, October presentation date for the board.
Okay.
So any other, concerns? Is any of the committee members, do you have any hesitancies, or are you feeling pretty good about things?
So this is Ismailia, Brian. August 4th, it will be from 1 to 4, the meeting?
Yes.
Okay.
Is that one on your calendar? Were you included or was it scheduled before you were formally added?
I don't know. I might have it.
I think I added Ismelda.
Oh, okay.
This is fresh.
Okay, thank you.
But I
Okay.
think I did it after the formal meetings were set up.
If we need to confirm, we'll follow up with Rebecca after she gets back. Because if you leave it to me, we all know what's going to happen, if anything. It either won't happen or it'll happen wrong.
I might wind up leaving that meeting a little bit early on the 4th. It's my wife's birthday that day, so.
Oh, yeah.
It's okay. Honestly, for the committee members who've been on the committee for a while, it's the same sort of deal we've done the past few years. We'll have the coordinating council and the Health Equity Work Group there this time, but it's you've heard all those presentations before, Steve. So we all know where we are and where we stand, and so I think your anniversary might be a little more important, I'm guessing.
Oh, it's Steve's wife's or his birthday,
Or
his wife's birthday. It's my wedding anniversary. And it's also Barack Obama's birthday for what that's worth.
Yeah, I know. Hey, you want to hear that? So my wife's birthday is on Barack Obama's birthday. Joe Biden's birthday is my birthday.
What?
Is that crazy? That is the craziest thing, man. I know. We just went wild those 4 years, those 8 years. I was like, what?
All right. So any other thoughts for the good of the order before we cut you loose? Awesome. Thanks again. Great discussion. Love the feedback. As always, you guys are really good about giving me direction. And so I feel like I have my marching orders, and hopefully I'll have everything ready and good to go and ready to get approved for August. If you guys have any questions in the meantime, again, feel free to send me questions, but always include Rebecca. Again, just to be safe. I see one more comment before I adjourn. Oh, that was Kelly. Perfect.
Yeah.
Thank you, everyone. Have a good afternoon.
Yeah, everyone take care.
Bye.
Bye-bye.